Hello, everybody. I'm Al Story. I'm clinical lead for a pan-London street outreach service serving inclusion health populations across London. So we've been outreaching, testing and supporting treatment mainly for the big ticket public health diseases, tuberculosis, hepatitis C and HIV, and offering immunisations and support with whatever else life throws at us for nearly 2 decades. And for my spare time, I co-direct the UCL Collaborative Centre for Inclusion Health with my colleague, Professor Andrew Hayward. And we at the centre and here at UCLH with the outreach team were extremely concerned when we saw news of COVID on the horizon, mainly because the early data was really pointing to a higher risk of severe disease and mortality amongst people who've got pre-existing clinical risk factors, mainly chronic diseases, the same sort of list of chronic diseases that make you eligible for influenza vaccination. And so we were very concerned about the risk of excess death amongst the populations that we serve. At the time of year, many of the people, particularly those experiencing homelessness, were temporary emergency communal shelters. So they were sharing the same airspace. We knew that COVID was a respiratory pathogen. We knew that it was most likely transmitting by droplet nuclei, even though at the time that was quite a contentious position. And we also knew from a lot of research that we've done that there was a very high burden of these clinical risk factors amongst homeless people whose health experience is really characterized by quite early onset complex comorbidities. So with colleagues here at UCLH and with public health colleagues and epidemiological colleagues at UCL, we devised a plan, a clinical plan to respond to the COVID pandemic as it was hitting us. We launched this plan on the 12th of March at a conference in London, which was quite fortuitous because it was a large gathering of colleagues who all work in inclusion health. And we were able to get quite a lot of instant buy-in and to mobilise pretty much the workforce for London and the UK in this one conference. And we launched a plan that was basically underpinned by simple public health principles. It was about triaging people for risk factors, testing them, even though right at the beginning we didn't even have access to testing. It was about getting people into a safe space, into a safer environment. That meant out of communal air spaces and into their own rooms with their own bathrooms. We knew that many hotels were going to be vacant, perhaps for quite a long time. And it meant that we had to provide a safe isolation for people who were symptomatic and people who were testing positive. And the plan was called Triage-Test-Cohort-Care. We launched this plan early on. It was launched officially right at the before we sort of started getting people in off the streets. And the government got right behind it, and they supported a public health response to the pandemic for homeless people with the Everyone In programme nationally. And that programme was designed to get people out of communal shelters, people off the streets who are rough sleeping, and to provide them with safe own room accommodation. Now I'm going to hand over to my colleague Bean, who's going to talk a little bit about the Everyone In programme, which was launched really on the right at the beginning of the pandemic on 16th of March. So before the national lockdown.
Yeah, so my name's Bean. I'm an outreach worker with Find and Treat, working with Al. And I have lived experience of being homeless as well as working with the NHS. And yeah, Everybody In was absolutely brilliant. Getting everyone off the street and into secure accommodation is like, anyone that works with homeless people has wanted that since, day one. And it's always been said that can't happen, that'll never happen. And it happened. It happened like in a week. It was absolutely brilliant. And now that everybody has been in for a year, it's kind of I think it's proved the point of everyone that's ever worked in this sector that like health and housing go together. Like I was speaking to some people from A&E the other week, and it's been very quiet on the homeless front in A&E. in the last year because everyone's got somewhere to live now. Well, not everyone, but, most people. And once you've got somewhere to live, you don't get sick.
Hi, so I'm Miriam. I'm a public health consultant now, or public health registrar when I was working with Find and Treat on the pandemic response. So as Al has outlined, it was identified quite early on by the Collaborative Centre for Inclusion Health that this new disease was presenting particular risks to the homeless population, and we realised that it was not only people who were sleeping rough and didn't have anywhere else to go who were at risk, but also those who were accommodated in places that had any aspect of sort of communal living. And of course that meant our existing hostel network and potentially night shelters as we're coming into winter, and that there were generally quite large risks, in the accommodation setting where homeless people experiencing homelessness might be residing. And we needed a system of ensuring that any symptomatic residents, any early cases were identified as soon as possible. If we were to intervene, provide testing, treatment, alternative accommodation, if we were going to prevent large outbreaks, which could be catastrophic in this population, given the health needs and vulnerabilities that Al has outlined, we really needed to be on the front foot. So we established a surveillance system to monitor cases in these complex settings. And we initiated this surveillance by surveying the existing hostel network. So we had really good network of contacts via Find and Treat and the outreach setup that has been in place for so many years. And actually, that was a really common theme throughout this work. Actually, was the value of networks and of those trusted relationships between Find and Treat, between the outreach workers and the settings and the population that we're serving in this situation. So we gathered information about the hostel settings, so the accommodation type, the communal facilities, the steps that they'd taken so far to try and reduce risks. And I should say that this built on a lot of really great work that had already been carried out by our health colleagues at the GLA, at the Greater London Authority. And throughout the pandemic, they did an incredible job of coordinating the response and a lot of the homeless work that went on throughout the pandemic. So purpose of the baseline information we got was to sort of understand the accommodation picture, but also to initiate settings into ongoing, regular, active surveillance and reporting. So any setting that we could get our hands on received a daily monitoring survey from us. We encouraged them to do daily welfare checks with their residents so that any person exhibiting symptoms would be identified really early on, so that information would come back to us. We could straight away make contact with the setting, do a clinical triage process with one of the Find and Treat nurses, and then if the circumstances required it, then get the team out so they could test the person showing symptoms, identify their close contacts, do that initial contact tracing in the setting, and understand whether we needed to cast the net wider, maybe we needed to do whole setting testing. And it was just a way of providing that sort of immediate, agile testing, identification, and response, so that we could pick up any cases very early on and avoid any outbreaks in those settings, which, as I said, could be really quite serious given the vulnerabilities in the population. So all of that information around triage, testing, outcomes was all fed back into the surveillance system. So we really started to build a good picture of how COVID was affecting this population, and opportunities for us to intervene and provide advice around infection prevention and control, adjusting how the settings were used, how people were using bathrooms and how meals were provided, what could the settings do to try and support people in their isolation. Maybe that's taking medicines, providing additional hand washing facilities, closing to visitors, all that sort of on the ground immediate infection prevention and control advice we were able to provide in an agile way, and provide that support to the settings. So the surveillance project itself grew quite a lot over the months, and that's a real testament to the work of the peer outreach team and Find and Treat. So they were doggedly trying to identify additional settings, other hostels that hadn't come forward to us, who hadn't made contact. They were reaching out to them. So there's this surveillance process that we're setting up. It's your access to testing, and really encouraging more and more settings to come on board, kind of come into the fold, and be part of regular monitoring and surveillance, so that we could do that testing should the need arise. We were also very well networked with the sort of strategic board that was looking after this work. So that's Find and Treat, the Greater London Authority, local directors of Public Health England, coming together at strategic levels, so that across London it was known that Find and Treat were offering this surveillance, this testing, and that was the route in. So throughout the pandemic, we were local authorities were standing up more and more accommodation under everyone in, and because of the networking we were doing, they knew to get in touch with us, to get in touch with me, so I could get in touch with the settings and bring them into that surveillance, so they had access to testing as and when they needed it. And so during the first wave, we had about 250 settings in the end, regularly submitting information to us, and that was a huge achievement, considering we stood that up from nothing. So yeah, I was really proud to be a part of that. And something else that was really important whilst we were doing this work was ensuring that engagement between Find and Treat and the sort of the outreach aspect of the work, and making the link to the mainstream pandemic response. So cementing our connections to London Coronavirus Cell and Public Health England, and making sure that we could agree information sharing processes, business processes going forward, so that the work that we were doing with the homeless population didn't just sit on the outside of the mainstream response, where inclusion health work often tends to sit. It was really important that we came out of this having integrated the work into the mainstream pandemic response. And I really hope that that's part of the legacy of this work. And the testing carries on. I think we've tested some 4,000 people to date. And so we're still heavily involved in supporting the pandemic response. That's all from me.
Hi, I'm Binta Sultan. I'm a consultant physician with Find and Treat, and I'm going to talk a little bit about the work that we've been doing during the pandemic. So, as Find and Treat is, as Al said, a specialist inclusion health service, and we implemented several programs of work during COVID. One of the most significant was providing COVID care facility. So this was a facility for people who experienced homelessness to be able to, who were COVID positive or had symptoms, to be able to safely self-isolate. And this was set up at a hotel in City Airport. And we were supported by MSF, which was the first time that MSF had been deployed in the UK, and by the Thames Reach Housing Team. And that was a collaborative project which saw about 40 people experiencing homelessness, which is actually more than the number of people who went through the Nightingale at that time. So a significant piece of work and a really important space for people to be able to self-isolate safely and be monitored, and then move on to accommodation from there. Other pieces of work that we implemented during the pandemic were, as both Al and Bean have said, Everybody In was a huge public health intervention, and what we saw was an opportunity as a specialist inclusion health team to provide healthcare, integrated healthcare. One of the things we did was use the opportunity to do health assessments, rapid health assessments on the people who were accommodated in the hotels and emergency accommodation. And what we implemented was our rapid health needs assessment called the CRESP tool, which stands for COVID-19 Homeless Rapid Integrated Screening Protocol. And it was a mostly telephone-based remote health assessment conducted by a clinician, and they would speak with individuals who were accommodated in the hotel. And it was a comprehensive health assessment, capturing information about medical need, social need, psychological need, drug and alcohol needs. And as part of that assessment, people were linked in with GPs if they were unregistered, and whatever unmet health needs were met by referrals and linking people into services. From that health assessment, we were able to capture a lot of information about the health needs of the population at that time. We found that a high proportion, so 9% of people were classed as extremely clinically vulnerable to COVID, and more than a third of people were clinically vulnerable to COVID. We also found that there was a significant proportion of people who had experienced head injury and cognitive impairments, so close to 30% of people. So this health assessment was really valuable in informing onward care for people and supporting people into their accommodation with the right sort of support around them as well to help with tenancy sustainment. Other things that we implemented during the pandemic as well was we saw this as an opportunity to also outreach testing for blood-borne viruses, so for HIV and hepatitis C and hepatitis B. And we tested more than 1,500 people in the hotels. And what we found from this work was that a significant proportion of people, so close to 3% of people we identified living with HIV, and just over 50% of them were on treatment. So high proportion of people with HIV and a very low proportion of people who had been engaged with care. And this programme of testing was very much led by the peer outreach workers with some clinical support, and peers supported people into treatment, and a significant proportion of those people are now in treatment and in care. And the other bit of work that we've been doing more recently is doing some work with street-based sex workers in London, and we've been taking our van out and doing some night outreach sessions, providing sexual health testing and BBV testing. And again, this is an integrated approach. So we have the housing outreach teams come out with us and drug and alcohol teams come out with us. So 70% of the mostly women that we see are unstably housed, a significant proportion are rough sleeping, and a significant proportion, over 50%, of are currently using drugs. So a very vulnerable population with housing and drug and alcohol needs. And through this work, we found that 90% of them so far have been diagnosed with an STI. Almost a third have syphilis. And we've been able to both diagnose and provide treatment for them, and also provide some housing and drug support as well alongside that.
So we find ourselves in a science versus nature scenario. We've been incredible at actually getting vaccine out there at scale, and through the work of our team and many other colleagues, particularly again a nod to Andrew Hayward, who presented the evidence to Joint Committee of Vaccination Immunisation to clearly lay out that the population that we serve should be prioritised for vaccination, not only due to their clinical risk, but due to the high risk of outbreaks in the congregate settings. And so we were able to start outreaching AZ vaccine, AstraZeneca vaccine, quite early on. And again, in our DNA, the model is to take services to people, and we've been able to scale and deploy multiple teams across London, across the city, in every nook and cranny, to actually take a vac service to people who are still in accommodation. More challenging in terms of rough sleepers. There's a large street population, unfortunately, that need to be reached, but we're working through that. But we do face some challenges, not least in terms of hesitancy, which is a major challenge. And I'm going to hand over to Bean now, who's going to give us a ringside view of some of the challenges of actually persuading people to take up the offer of vaccination.
So, yeah, people declining vaccine. We've had lots and lots of reasons why people will say no. A lot of it to do with stuff they've read on the internet, and Bill Gates putting microchips in them and stuff like that. But quite a few people have said to me, I don't want COVID to go away, which I thought, that's weird. But then a few weeks ago, a guy said, I don't want COVID to go away, because I was on the street for 2 years, and then COVID came along. Now, for a year, I've been living in a hotel, and like, my situation has been prioritised, where that's never been the situation before. And I couldn't really argue, you know. You can't say, well, you know, get vaccinated and then maybe you'll go back to the street. Like, if I was him, I would be saying exactly the same thing.
So I'm just going to wrap this up now. And really just going back to what Bean said about this just being absolutely unique and, you know, completely out of the blue as an event, to make an unconditional offer of accommodation to people who had, many of whom had experienced rough sleeping for years and exclusion from multiple services for years, to give them the dignity of their own front door, their own bathroom, 3 square meals a day, and some support from an expert staff team, was utterly transformative. It is absolutely clear that having somewhere to live is good for your health. You know, we've known this for years, but homelessness, and particularly street homelessness, rough sleeping, had begun to be seen as some kind of politically intractable, some insurmountable problem. And it clearly isn't. It clearly isn't. This recalibrates our concept of what is possible. This recalibrates opportunity for the future. This experience, as it has been for so many people, should be transformative for providers and policymakers alike. And we need to up the ante. We need to raise the bar in terms of our aspirations for tackling homelessness, which is an aberration in a wealthy country like the UK. We need to think about what can we gain that's positive from the legacy of the pandemic. It's not going to go away. COVID is an endemic pathogen now. We're going to need to learn to live with it and build it into the furniture. And part of learning to live with it is thinking quite deeply about what is a safe environment. And it's quite clear to me, to our amazing team, and I hope to you, that we can do better. This should have been the world's largest housing first experiment, and it still can be. We need to make sure that people have the opportunity to have the safety and dignity of their own front door, their own place to live, some privacy, some dignity, and that should be the new norm. Thank you very much.